All right. So good afternoon, everyone. Today's didactic, we do have a journal club. So this was an article that I had come across not very long ago that is looking at the association between cannabis use and schizophrenia. So objective-wise, just for our quick didactic, we're just going to walk through this particular article, but then really think about what do these findings mean. May not mean quite what some people may interpret from the title, but what can we do with this information? So I'm going to walk through starting with some background, look at what their objectives were, how they set up the trial in order to accomplish those objectives. We're going to spend quite a bit of time looking at the results of the trial, and then discussion and clinical impact. So citation is here. Jamie sent out the article a couple times. I do believe it is open access, so hopefully everyone had a chance to be able to get a hold of it. And I thought it was interesting. So this particular trial, cannabis association with schizophrenia isn't necessarily new, but this particular trial really wanted to focus in a little bit. In their background, they were really discussing how the use of cannabis has taken off. There's significant inconsistencies now, not only between different countries around the world, but also between different states within countries, probably pointing the finger a little bit more at us here in the United States. And overall use has been going up pretty significantly. So it's estimated that in 2019, over 180 million people had used cannabis within the last year. The National Institute of Drug Addiction does participate in a study. There are tours going by. It's a little bit distracting, so I apologize if you guys can hear that. I think they have folks coming to campus for something, so I do have my door shut, but they were pretty loud. So back to cannabis use. The National Institute of Drug Addiction does surveys looking at how frequently folks are using substances, and cannabis is one of the most utilized substances that's reported, right up there with alcohol, with tobacco. A subset of that particular survey, they were looking at young adults, so those that were between 18 and 24 years, and they wanted to compare the percent of those respondents, so the percent of 18 to 24-year-olds who said that they have been using cannabis in the last year. They compared it over the last, over a past decade. The most up-to-date information I could get was from 2021. And about 29% of the young adults had reported using cannabis in the last year. In 2011, that increased to about a third of respondents, so 34% in 2016, and it's just shy of half of the respondents in 2021, so up to 43%. Not only is use increasing, but the potency of the products that are being used is also changing with the changing regulations and access and everything else. So oftentimes experts will describe cannabis potency by looking at the percent of active ingredients. So in this case, they focused on the delta-9 tetrahydrocannabinol, so our THC concentrations. And when they looked at concentrations of available on the street cannabis, they found that it was about 9.75% THC in 2009, and it was just shy of 15% in 2018. I've seen estimates, so not averages, but estimates. Some of the products that have been seized routinely have been over 20% in the last few years. And there are some that even are pushing 30 or higher percent. I think 33 was the highest that I saw. So it's using it more, more individuals are using it. It is more potent, and the concentrations and the ratio between THC and CBD is also shifting dramatically, where some of the considered more potent or THC focused agents the ratio of THC to CBD, as you can see, has essentially quadrupled. So it's a 4-fold increase in the amount of THC to the amount of cannabidiol in some of the products, which has raised concern because there really isn't an ongoing narrative, education, or focus on what type of effects might this be having. So folks are using it for a number of different reasons, as well as for medicinal reasons, but collecting and really assessing some of the safety data isn't being done in any type of a standardized way. One of the reasons that that's a concern is it's been recognized that use of cannabis has been associated with psychosis and the diagnosis of schizophrenia. And I just want to make the distinction, associated. We're not talking about causality. We will not be talking about causality, so spoiler alert, throughout the rest of today, but that there is an association between the two. This was established by an article that was published by Dr. Marconi and colleagues in Schizophrenia Bulletin back in 2016. So they did a systematic review and they looked at more than 500 articles that were out there evaluating cannabis and other illicit substance use and psychosis or schizophrenia. They narrowed it down to 18 that had the specific information that they were looking for. And what they found was that there was an association between cannabis consumption and psychosis. And when they evaluated the trials, I really liked this graph, which is why I borrowed it from the paper. It's on the top on the right-hand side of this slide. The odds ratio is on our y-axis, and then cannabis exposure is on the x-axis. So 0 cannabis exposure is essentially that is a non-user. So somebody who is not using cannabis, who is not really exposed to cannabis. The gradations go up based on exposure and frequency. So if individuals are using cannabis once a year, once every 6 months, then they would be closer to 0. Those that are using it much more frequently, monthly to weekly to daily, are going to fall more closer to 1 on the end of the x-axis. And as you can see, as the cannabis exposure goes up, so the more often or frequently an individual is using it, the higher the odds ratio. So the more likely an individual is at risk for having psychosis and requiring some type of medical assistance. So they definitely saw that, and their estimates here at the bottom were it's about a 4-fold risk for individuals who are moderate to heavy users of cannabis. And likely the biggest risk category they had identified were males that were early heavy users and were using it frequently. So those really were the ones that they saw carried the heaviest risk of developing psychosis as an adverse effect. Now, because of more of the information coming out that seems to also correspond to that, some questions are being raised. Are there target populations? So are there folks that we can target that may make a bigger impact on cannabis use and the development of psychosis? These particular authors decided to look specifically at the Association for Cannabis Use Disorder. So not just folks who are using, but those who have the actual diagnosis of cannabis use disorder and those who are diagnosed with schizophrenia. So that does narrow both categories in a little bit, as opposed to any type of psychosis just presenting for psychotic symptoms. So they were looking at these 2 discrete variables. So they wanted to see if it was different between males and females. They wanted to see if the differences between males and females changed over time. So they're going to look over a longer chronology of time and by age. So are younger folks at a different risk from those who might be a little bit older? They also wanted to see proportion-wise how many of the cases of schizophrenia may be influenced by cannabis use disorder, and does that vary by males and females, and then does that vary over time by age? So they were looking at a handful of different factors. So how did they do that? For us in the United States, I think it would be really difficult to be able to get that information consistently, especially recognizing they wanted to look at this over time. They did this based on a registry cohort study. So they used the Danish registries that included medical data from folks who were in the country and accessing medical services at that time. They were able to pull in a couple other factors that they thought may potentially play a role. They did capture family medical history, family psychiatric history, and in their statistical analysis, they were controlling for individuals who had alcohol use disorder in addition to cannabis use disorder, and those that were using other specific medications. So as they essentially went through the registry, the database, looking at all of this information, they were pulling out those that had cannabis use disorder. Do they or do they not also have schizophrenia? What are some of the ages associated with that? And then did that change over time? So they used two different statistical models to be able to try to answer those 4 questions that they set up. So the first is the Cox proportional hazard regression analysis. So it's coming up with hazard ratios. So how likely is there to be an association between cannabis use disorder and schizophrenia? And then they were looking at a Poisson regression, specifically to look at cannabis use disorder. Does it have an impact on males or females? And does age play a role in the incidence of schizophrenia? With that in mind, the incidence of schizophrenia would be expected to change over time. So the risk for someone who may be in their early to young adulthood may be very different in someone who's a little bit later in adulthood. I don't want to say the end of adulthood because I fall into some of those categories down there. So the way they set up those age ranges was 16 to 20, 21 to 25, 26 to 30, 31 to 40, and then those who are older than the age of 40. So they were just essentially chugging through a lot of data. Anyone who had data in the Danish registries and were between the ages of 16 and 49 years old during the time frame of 1972 to 2021 were included. So they really were capturing a large number of individuals over an extended period of time. If an individual didn't have data or their data was incomplete in the registries, they weren't included. And if they weren't between 16 and 49 over that period of time, they also weren't included. So they really were just looking at everyone, all of the data they could get their hands on, which is kind of nice because it's going to give us a pretty big snapshot. So they were able to get data on over 6 million patients, so just shy of 7 million patients. Of these patients, they identified more than 45,000 cases of schizophrenia. And you can see the breakdown of some of the characteristics, the demographic characteristics that they included. So a little more than half were males. Yes, not necessarily a surprise. About 10% were born, were considered foreign born, so they had moved. 0.4% had a parent that had schizophrenia. About 12% had a parent that had another type of mental illness. Short of 10%, so just under 10% had an alcohol or other substance use disorder. About 1% of the patients they were looking at did have cannabis use disorder. They had 6% with alcohol use disorder, and then about 3.5% with another substance use disorder. So they had a pretty significant variability in the cohort of patients that they were looking at. So as they pooled all of that data and ran their statistical analysis, they found that the risk of schizophrenia in patients with cannabis use disorder was elevated. So I showed you the Marconi data, which said that the odds ratio was about 4. This showed it slightly less. So it was about 2.3 was the adjusted hazard ratio. So they were taking into account a few things. As a reminder, though, these patients had to be diagnosed with cannabis use disorder and had to be diagnosed with schizophrenia, whereas the Marconi data included trials that just looked at patients that were using cannabis but didn't have that diagnosis, and those that had psychosis and not necessarily diagnosed with schizophrenia. So even with this more focused criteria, they still had an increased risk for the, there was a pretty strong association between cannabis use disorder and schizophrenia. One of the main things they wanted to look at, though, they weren't surprised, that was what they expected to find, is that there would be an increase. But was there a difference between males and females? The answer was yes. That chart was a little smaller than I was anticipating. So I'm going to go through my papers here for just a sec. So they did see a difference across the board between males and females. Males had a slightly higher hazard ratio for the development of schizophrenia than what they saw with females. So you can see the overall hazard ratio was 2.4 for males and 2.02 for females. So still over 2, but we did see a slight difference. And then when they broke it down into those age ranges, we saw a difference there as well. I liked the graphical representation. It kind of shows you over time what the hazard ratios were. So for those folks that had cannabis use disorder in the 70s and 80s, they still were right around a hazard ratio of 2. So really starting in about the 2000s, we see that start to rise just a little bit, at least on the graph for the males. For females, it's a little bit of the opposite. So they started out a bit higher and then look to maybe have come closer to 2 and almost be dropping below that in this female demographic over time. So yes, it looks like there is a difference between the two genders, and yes, it looks like there is a difference between them over time. What they're seeing with the models and the trends looks like they're going in different directions. I like this because it broke it down based on, so all of the male data are those 5 graphs across the top. The female data are the 5 graphs across the bottom, and it's specific to the different age ranges. So 16 to 20 are the 2 boxes on the far left, and 41 and above are the 2 boxes that are on the far right-hand side. So as you can see with the male patients in that top row, we do tend to see exactly what that other graph looked like the hazard risk, that hazard ratio appears to be increasing with one exception, and that's those that are 41 and older. So there, the data was a little bit less consistent and not quite as clear of an increase over time. For the females, they also look like some of them are decreasing, but it's way less consistent. So the 21 to 25-year-olds, that second box looked to jump, had been a decrease, and then it seemed to pop back up. The 26 to 30-year-olds, that third box right there in the middle, also seem to kind of yo-yo back and forth. And those that are 41 and older actually look to be doing the opposite. So we see that looks to be going up. So it didn't appear from the female perspective we had as cohesive a message of which direction is this moving in over time. So that one's still to be determined, but overall for the males, it does appear to be increasing over time. And this I thought was a great kind of recap of that same data. So they used a parameter called PARF, population attributable, I'm tripping over my words here, population attributable risk fraction. I'm just calling it PARF because I obviously can't say attributable. The yellow dots are males, but when they modeled it, taking into account a few other risk factors, so confounders that might increase somebody's risk for the development of schizophrenia, they did adjust that. And you can see the red line is the trend for males, and it is very clearly increasing over time. For females, the purple dots are the actual data, and then the modeling, which takes into account a number of those confounders, is what the black line is. So despite seeing some of the inconsistency, we do see a slight increase over time in females as well. And one of the things that was mentioned, and was mentioned in the discussion that I'll mention here in just a couple minutes, is the fact that these are only folks that are diagnosed with cannabis use disorder. It is not taking into account when they started smoking, how frequently they are, what's the potency of what they're using. So even though the specific data for each of the individuals may go up and down, a result of all of those other factors, it's more potent. It's way more potent. There are more people who are smoking or who are using cannabis products, because most of them may be vaping. Over time, that may be why we see more of a consistent trend when they looked at it this way. But either way, that appears to give us a population that we could target for interventions to maybe offset some of the psychosis and diagnosis of schizophrenia. So in looking at the discussion, they said, yes, absolutely, there was a strong association between them. And there was an association, cannabis use disorder and schizophrenia, and there appeared to be a stronger one for males versus females. The group that had the highest incidence rate of schizophrenia were males that were 16 to 20. So very consistent with the other data that we had. Those younger male patients do appear to be in a higher risk category. As I mentioned, we don't know anything about the potency, what age they started use, how frequently they're using. So those are outstanding factors, but that group does continue to be at the top of the list for risk. One thing that the authors wanted to be sure was pointed out is this is an association study. So individuals with cannabis use disorder have a strong association for diagnosis of schizophrenia. It does not necessarily mean that the cannabis use disorder causes schizophrenia, and there is kind of a developing narrative going on that maybe folks that are at risk for schizophrenia seek out cannabis use and are using that differently. So we're not able to answer that question based on the data that we have. So just, yes, there is an association and it's giving us a population that we could target. So strengths and weaknesses of that trial. I'm going to start with the weaknesses, the limitations. They were required to have those diagnoses. So this was a much more focused and refined population. If they didn't have cannabis use disorder, if they had psychosis, but not specifically schizophrenia, they were not included in those analyses. They could not capture all of those confounding factors, and the information on when they started using, how often they're using, what's the potency of the products that they're using is not available. We do know that it changed over time, and they know generally about what the average is of the available marijuana products based on their national trends, but it doesn't necessarily mean that that's what most of those folks are using. And we are not able to establish causality, so we're only saying that there is an association between the two. But on the flip side, this was pretty powerful data to have such a large registry that had consistent and comprehensive information over such an extended period of time. So we're talking more than 5 decades worth of data that they had captured and were able to process. They did not have to go through multiple steps in terms of consent because they were able to have it be anonymous data. It was de-identified for the researchers. And they proposed that this is fairly generalizable, at least to the Danish population, because it was the National Registry over an extended period of time. It seems to represent them relatively well. So what? So it looks like it increases. You're probably not surprised. There looks to be a difference between the two, between males and females. It adds to the information that's available on some of the risks. So as cannabis products become less regulated in several areas, it increases the likelihood that recreational use is going to go up. We see the numbers of usage go up, and the potential implications for long-term effects in those individuals, we don't have a clear idea yet. This gives us a snapshot of, hey, this may really be a problem. When they analyze the data, so those parameters that are risk functions, the PARF, they use that to mathematically estimate about how many cases of schizophrenia do they believe were attributable to the cannabis use disorder that they wouldn't expect without that being a risk factor. For males, it was about 15%. So about 15% of those cases are thought to be preventable if they can avoid the development of cannabis use disorder. For females, the percentage was 4%, so that may not be quite as robust a population to target. So there is discussion about increasing education, screening, identification, and intervention on problematic cannabis use, specifically as a means to then minimize the future development of psychosis, specifically in this trial, schizophrenia. So really looking at it for education, that there are likely long-term complications. This is just one example. And again, which direction does it go in? Maybe that's a good way for us to identify folks that are at extreme high risk for the diagnosis of schizophrenia. But with 15% of those cases potentially preventable, that seems like a really good population to start with some public health initiatives. So with that, I will stop my share.